Hello students, hello, good morning all of you, good morning. Welcome to our final session. Am I visible to all, am I audible to all? Is the audio video all clear? Yes, and am I visible to all, am I audible to all? Is the audio video all clear? Okay, so let us begin our discussion. First, a quick recap and a precap. What is the agenda for the day? We are going to have a 3-hour session. Okay, we are going to have a 3-hour session. Okay, totally. In that, we'll give you a small break in between at around 11 o'clock, just for a small 5-10 minutes break. And now, please understand the whole dynamics, matlab the whole plan of the action. Okay, so we are going to discuss two main topic wise. What is remaining is IUGR, almost never asked. But just to complete the topic, I will teach you anyways, because in IUGR we teach you also something called as color Doppler, which is never asked. Then second, RH negative. It is a very interesting topic. Many students do not know this, slightly difficult. And yes, recently also the question was asked on this. So RH negative. And the last half an hour, 1 hour, we are going to discuss all the images. Few of them are repeat. Like already I have shown you just as a revision, and few are some new images which I haven't covered during the course of the lecture. Rest all the images, if you see right from the beginning, first lecture, PCOS, endometriosis, IVF, ICSI, tubal patency, everywhere I have constantly shown you the images. Similarly, all the breech maneuvers, ECV, IPV, internal podalic version, APH, PPH, everywhere all images have already been shown to you. Yes or no? Thumbs up if you remember. Okay, including the uh, sonography, gestational sac, the yolk sac, fetal pole, all that NST color, all the images have been shown to you. Okay, is this clear to all of you? Yes, and rules remain the same. Ask question, answer questions. Don't go home with any doubts, and please respond to the answers. And last thing, please use only Telegram. Okay, we have 160 members on this group. Please use only Telegram to communicate with me during the lecture. If I ask you something, if you have to answer, if you don't understand anything, if you want me to repeat something, only through Telegram, because the chat box during the lecture I cannot access. Okay, I cannot access the chat box during the lectures. So you will use only the Telegram channel to communicate with me throughout the lecture. Okay, is this understood to all of you? So with this as the background, let us discuss the first topic, IUGR, intrauterine growth retardation or growth restriction. Okay, now what is the meaning? It is birth weight less than the 10th percentile. So whatever for the gestational age, so whatever is the birth weight जो होना चाहिए normal, if it is less than the 10th percentile, then I call it as IUGR. Now it is of two types. Anybody? Symmetric IUGR and asymmetric IUGR. Anybody? Which is better to have? Which is better to have? अगर by chance अगर एक होना ही है, so first of all, what is the meaning? What is symmetric IUGR? What is asymmetric IUGR? Anybody? Yes. Okay. By the way, this is only 20% cases, so that is rare and good for us because it is more dangerous. And 80% of the time, majority it is this. Okay. So now, yes. So wrong. Okay, wrong. Okay. RR, NRR. Yeah, all of you wrong, Navraj. Okay, symmetric is more dangerous, much more dangerous. Asymmetric is always better to have. Yes, very good, Shobna. Okay, so now please pay attention. All of you, please pay attention. Point number one. Point number one is that first understand the meaning that in symmetric IUGR, head is also decreased, abdomen is also decreased. So the whole baby is symmetrically small, but that is not good. In asymmetric IUGR, head is actually normal. Head appears larger, but head is normal. Only the abdomen is smaller. So, पहले ये meaning समझ में आ गया? Yes. Now, please understand the main differences start from here. That in symmetric IUGR, the injury or the insult, the word used is insult. Okay, insult matlab when the injury happens to the baby. So the injury or the insult is early in the pregnancy. That means early in the pregnancy, the baby will get attacked. So the causes are itself more dangerous. Anybody, what are the causes? Some chromosomal problem in the baby, genetic problem in the baby, or some infection like your torch infection, which your pediatricians will teach you. Okay, because that is common pediatrics. Okay, so the complications, the attack to the baby happens early. So because it is early in the pregnancy, please understand the cell number itself is decreased. Cell number itself is decreased. Okay. Is it clear to all of you? And therefore the problem is, please pay attention, that it is a defective baby which will remain defective lifelong. Matlab basically recovery is not possible. Can this baby recover? No, sir. Recovery is very, very difficult. Now, in asymmetric IOGR, the insult happens late in pregnancy. Like example, 26 weeks, 28 weeks, 30. Yes, the most common example is your preeclampsia. Basically, your PIH. I told you PIH is always after 20 weeks, and that also most of the time after 28 weeks. Okay, so preeclampsia, then your basically uteroplacental insufficiency, smoking agar hai, malnutrition, basically all causes of uteroplacental insufficiency. So what happens is that the cell number is normal. What you may have, cell number is normal. Only the cell size is lesser. Are you understanding the difference? And therefore, bahar aane ke baad, when you give baby, when the baby comes out, and when you give baby proper khana, pina, breastfeeding, then the complete recovery is possible. इसका मतलब क्या है? All of you please pay attention. The recovery is possible. इसका मतलब क्या है कि suppose we have a baby, suppose we have two babies. Okay, suppose there are two babies. ध्यान से सुनेंगे. What is the meaning of this? That here recovery is possible. मतलब sir, suppose we have two babies in front of us. One is a healthy, I'm writing H, healthy, normal 3 kilo baby. This is just an example. And दूसरे बाजू में I have got a IUGR baby which is 2 kilo at birth. Okay, because average Indian baby weight 2.5 kilo. Remember, average Indian baby weight 2.5 kilo. That means majority of the babies when they are born, they are 2.5 kilo at birth, 90%. Okay, but ये IUGR है. But this is your asymmetric IUGR baby. So what will happen is that example at 1 year, when you will weigh both of them, both will be roughly 10 to 12 kilos. So 1 year pe normal weight. That means this 3 kilo will become 10 to 12. This 2 kilo will also catch up and become 10 to 12. Thumbs up if you have understood this. That is the meaning of this. Sir, bahar aane ke baad, when you give baby proper breastfeeding, nutrition, khana, pina, everything, the baby can grow to its complete potential and there is a recovery possible. Okay. Okay, is this understood to all of you? Yes. So please keep all this in mind. Please keep all this in mind. And therefore remember that this is the meaning of this whole statement, that all of you, that here the recovery is not possible. That means this is a defective baby which will remain defective lifelong. Okay. Which will remain defective lifelong. Okay. And this is a recovery is possible. Okay, is it clear to all of you? So all of you, please look on the board very and the last and the most important, somebody, what is this brain sparing effect? Okay, okay, what is this brain sparing effect? Brain sparing effect kya hai, anybody? And it is absent over here and it is present over here, present in this asymmetric IUGR. Anybody? What is the idea? So please understand this. This is the basic difference. Is nobody going to ask you this, that birth weight below the 10th percentile is called as IUGR. Now in symmetric, the baby is symmetrically small. Your head is larger than abdomen. Actually, head is normal. Head appears larger. Ratios I will discuss in a minute, don't worry. Okay, mainly genetic causes infection. Causes are placental insufficiency, that means your uteroplacental insufficiency, preeclampsia. Total number of cell itself is decreased. I told you cell number is normal. Okay, and only the cell size is lesser, and complicated course and poor prognosis. Okay, and good recovery and good prognosis. And main, as I told you, insult is early in pregnancy, insult is late in pregnancy. And anybody, what is this brain sparing effect absent present? Any idea? Can you tell me what is this brain sparing effect? Yes, anybody? Any idea what is this brain sparing effect? So we will discuss this in color Doppler in some time. Basically, brain sparing effect का मतलब क्या है? Very good. Brain is not affected or brain is less affected. No, impending brain damage नहीं बेटा. Brain sparing effect. Brain is spared. Brain sparing. Sparing का मतलब क्या है? कि brain को छोड़ दिया. Brain is spared. Okay. When I say brain sparing, मतलब व्हाट इज द मीनिंग के ब्रेन को माफ कर दिया है, ब्रेन को छोड़ दिया है, ब्रेन को बैड इफेक्ट नहीं होगा. ब्रेन स्पेयरिंग इफेक्ट. ओके, okay, brain sparing effect, BSE. So what is the meaning is, please pay attention, that in asymmetric IUGR the baby is very smart. The baby is very smart, like all my students. Okay, the baby is very smart. Baby क्या बोलता है कि what organ is more important, let me give it more blood supply. And what is less important, yes, it's a mechanism to, okay, okay, the brain will get more blood supply. So it's a vascular phenomenon where brain will get more, or basically brain will get normal blood supply. There is redistribution of the blood. And baby क्या बोलेगा, abdomen को छोड़ दो. So abdomen will get less blood supply. So abdomen will get less blood supply. So therefore the liver will remain small, kidney. So therefore abdomen is going to remain small. Ratios we are going to discuss in some time. Okay. And if the abdomen is small, even renal, kidney is going to get less blood supply. Therefore associated oligohydramnios hota hai. Okay. Because I told you what is the major contribution for liquor? The fetal urine. Fetal urine contributes to liquor. So brain sparing effect का मतलब ये है कि whatever is the bad effect of IUGR, whatever is the bad effect or whatever is the adverse effect of IUGR, वो ब्रेन को नहीं होगा. ब्रेन इज स्पेयर्ड. समझ में आ गया? I repeat, brain is spared the adverse effect of IUGR. There is redistribution of the blood supply. Is this understood to all of you? Absolutely PG level, not even asked in PG entrance. FMG में तो 2-3 साल के बाद आएगा. Is redistribution of the blood supply, and the brain will receive normal blood supply or even increased blood supply at the expense of liver and kidney. So abdomen को blood supply कम हो जाएगा, liver kidney को blood supply कम हो जाएगा, therefore abdominal circumference will become lesser. Is this understood to all of you? So brain is not affected, what you said, or is it clear to all of you? Can I get 5 thumbs up? Oh, don't worry, all these points will be repeated in some time. Okay, now please pay attention. Two important statements. Next 10 minutes, whatever we are going to discuss, discuss is only about asymmetric IUGR. Symmetric IUGR, nothing much can be done. It's a defective baby. इसका कुछ नहीं कर सकते. Now, whatever I will discuss now in the next 15 minutes will only be about asymmetric IUGR. Okay. Now, please understand this. There is no specific treatment. There is no one drug of choice. You have to give patient high protein diet, good nutrition, correct malnutrition, stop smoking agar hai to, correct control preeclampsia, and the logic is to you keep on trying pregnancy, you keep on prolonging pregnancy till that 37 weeks of gestation where you can then safely deliver the baby. And many times we have to do early delivery also. Okay, so mainly in IUGR, it is about monitoring when to deliver, how to deliver. Two most important MCQs. Abdominal circumference is the most important marker on USG for asymmetric IUGR. Okay, all this is for asymmetric IUGR. So if the question comes, what is the most important marker on USG? Abdominal circumference. Okay, and color Doppler is the most important investigation in management of asymmetric IUGR. Is this two MCQs understood to all of you? Of course, I'll explain you the meaning. I'm not like that, just say the statement and go ahead. I'll explain you. I repeat both this statement please by heart. And what is the most important USG marker? It is your abdominal circumference. And what is the most important investigation in management? Color Doppler. Why? Because color Doppler will tell me when to deliver and how to deliver. Whole delivery aspect, 32 weeks per delivery karna hai, 34 weeks, 36 weeks, all that will be decided by color Doppler. Is this clear to all of you? Is this understood to all of you? Yes. So color Doppler is the most important investigation in the management of IUGR, and abdominal circumference is the most important marker on ultrasonography because abdomen is going to lag behind. Okay, now please pay attention. All this you don't have to remember. I'll just tell you what you need to remember. Abdominal circumference on USG is the best marker. Okay, and color Doppler is the most important investigation for the management of asymmetric IUGR. Okay, now please pay attention. This points number 4 and 5 I'm going to explain to you. First, understand the meaning. Okay, point number one, whenever you suspect there is IUGR, kabhi bhi laga ke there is IUGR, next thing color Doppler. Clear? Whenever you feel that there is IUGR, go for color Doppler. How will I know there is IUGR? Sir, either on my abdominal examination. Okay, sir, the abdomen is going to be per abdomen. I told you what will happen. The fundal height will be less. Okay, sir, uterus should have grown till here. Uterus should have grown till here, but uterus has only grown till here. तो ये हमारा fundal height, I told you, uterine size is less than weeks of gestation. So तुरंत आपको पता चला IUGR. Yeah, on sonography also, if you come to know there is IUGR, then also next thing directly go for color Doppler. Now, why I am saying this, all this, please understand, nobody will ask you, but just for you to understand. Okay, all of you look on the board. What it is that in the baby, we measure three parameters. Biparietal diameter on the sonography. Yeah? On sonography, for any baby, I measure three things. Biparietal diameter, femur length, abdominal circumference. Okay, I repeat, BPD, FL is femur length, AC is abdominal circumference. Now suppose when the patient is, say, this is just an example. Suppose if the patient is 28 weeks pregnant and she goes to the doctor for sonography, the head size will also come to 28 weeks. Femur length will also measure up to 20. How much it will measure, that you forget it. That's on sonography machine already written. Okay, if the femur length is this much, the size is 20 weeks approximately. The femur length is this much, the size corresponds to 24 weeks. If the femur length is this much, size corresponds to 28 weeks. And abdominal circumference also corresponds to 28 weeks. So this is absolutely normal baby. समझ में आ गया कि सर पेशेंट का एज, जेस्टेशनल एज इज ऑल्सो 28 वीक्स एंड बेबी का सारा पैरामीटर is coming to 28 weeks. Very good. But now you tell me, okay, sir, suppose the head is 28 weeks. Very good. Femur length is also 28 weeks, but abdominal circumference is measuring only up to 25 weeks. तो क्या है, कुछ तो गड़बड़ है. ये क्या है? यस, वेरी गुड पॉपी के सर यहाँ पे हेड का सही है बेटा. दीज आर यूएसजी ओनली, आई टोल्ड यू बेटा. ओके बिलाल, ये यूएसजी के ग्रोथ चार्ट है. ग्रोथ चार्ट्स तो डोंट कंफ्यूज द ग्रोथ चार्ट विद द पीडियाट्रिशियन यूजेस. यस, वेरी गुड. आरआर आईयूजीआर, लेकिन व्हाट टाइप ऑफ आईयूजीआर सर? दिस इज योर असिमेट्रिक आईयूजीआर. के सर है एग्जांपल है, ये खाली एग्जांपल है कि सर हेड हैज ग्रोन टू द, बेटा यू टेल मी, मेडी को आप मुझे बताइए अगर आपने प्रीवियस लेक्चर सुना है तो. ओके, दैट हेड हैज ग्रोन टू 28 वीक्स. फीमर हैज आल्सो ग्रोन अप टू 28 वीक्स, बट जो एब्डोमेन है हैज ओनली ग्रोन अप टू 25 वीक्स. सो दिस इज जस्ट एन एग्जांपल. ओके, बीपीडी मतलब मेडिको बाइपराइटल डायामीटर, हेड का साइज. ओके, बाइपराइटल डायामीटर. ओके, क्लियर? Yes, so please pay attention. This is just an example. It could be anything. It could be 30, 26. Okay, it could be 30, 26. मतलब sir, head has grown up to 7.5 months. Example. Femur भी 7.5 months. लेकिन abdomen has only grown up to 6.5 months. There is a lag. And all of you, can you tell me one point? Higher the difference, what it is? Higher the difference, less severe or more severe is the IUGR. Example है ये 30, 24. तो ये 6 वीक का लैग है. That means sir, yes, higher the difference, more severe is the IUGR. Nobody is going to ask you all this. Clap if you feel happy. Only for my love for the subject I'm explaining you this. I just repeat, ये पूरा explanation का मतलब एक ही था कि abdominal circumference on USG is the best marker. With abdominal circumference, I will, excellent all of you. I will repeat. Yes sir, head size, BPD we measure, femur length we measure, and abdominal circumference I measure. And suppose agar baby is 28 weeks. If the baby is 28 weeks today, all parameter should roughly come to 28 weeks. That is considered normal. But agar head is coming, example, to say 28 weeks, femur is also 28 weeks, that is very good, but abdomen is समथिंग 25 वीक्स आपका बत्ती चमकना चाहिए, बल्ब जलना चाहिए कि सर ये कुछ तो गड़बड़ है, दिस इज माई असिमेट्रिक आयुजिया. सिमेट्रिक में एवरीथिंग विल बी स्मॉल, इन सिमेट्रिक द होल बेबी विल बी स्मॉल. ओके, सो इन सिमेट्रिक आयुजियर में क्या होगा, अगेन नोबडी विल आस्क यू, बट इन सिमेट्रिक आयुजियर एवरीथिंग विल बी स्मॉल. That means in symmetric IUGR, just for your reference, nobody will ask you this. Okay, in symmetric IUGR, when the baby is 28 weeks, this everything will be 24, 24, 24. So head is also small, abdomen is also small. That is your symmetric IUGR. Forget symmetric IUGR, nobody is going to ask you this. Okay, is it clear to all of you? So again, this table, nobody is going to ask you. This is just an example, of course. This is an example. This is an example. Okay, at 28 weeks, if I do ultrasonography, this is how a normal baby will look like. And this is how. This could be anything. It could be 28, 28, 24. It could be 28, 28, 23. So higher the gap, more severe is the IUGR. Is this understood to all of you? And therefore, please understand this. There are two ratios. FL is femur length upon AC. And dusra is head circumference upon AC. Now can you tell me, when there is asymmetric IUGR, what is going to decrease? Abdominal circumference is going to decrease. Do you agree with me? Tell me yes or no. So if the denominator will decrease, what will happen to the ratio? Value याद नहीं रखना है. If I tell you, F in asymmetric IUGR, FL to AC ratio will increase, decrease, no change. In asymmetric IUGR, FL to AC ratio will be what? If I ask you, FL to AC ratio will be normal, increase or decrease? What is your answer? In asymmetric IUGR. Yes, common sense sir, कि डिनोमिनेटर कम होगा. नहीं ऋषि, डिनोमिनेटर कम होगा तो रेशियो बढ़ेगा. Isn't it? Ratio, overall ratio will increase. Mathematics. Abdominal circumference will decrease. Correct. Abdominal circumference is going to decrease. So if the abdominal circumference will decrease, ratio will what? Yes, ratio will increase. Okay. Okay, is this understood to all of you? So this they are not going to ask you. Please, all of you look on the board. FL to AC, 22% is normal. No need to remember value. More than 23.5 is IUGR. The ratio is increased in asymmetric IUGR. So FL to AC ratio बढ़ गया. And similarly, after 34 weeks, HC to AC ratio is normally less than 1. If it is more than 1, it is asymmetric IUGR. So I repeat, you don't have to remember the values. Just remember that on ultrasonography, these are the two ratios. And in all the ratios, the AC is coming in the denominator. Example, common sense ना, कि अगर एक नंबर है 10, उसको normally if I'm going to divide by 5, but 5 के बदले now if I divide it by 2, तो रेशियो ज्यादा आएगा ना आंसर. कॉमन सेंस ना. ये 10 को 5 से डिवाइड करेंगे तो आंसर मिलेगा 2, बट 10 को 2 से डिवाइड करेंगे तो आंसर मिलेगा 5. लॉजिक मैथमेटिक्स. इज इट क्लियर टू ऑल ऑफ यू कि व्हेन द डिनोमिनेटर विल डिक्रीज, द रेशियो विल ऑलवेज इंक्रीज. इजंट इट? Yes. So these are the two ratios which you measure in IUGR. One is FL to AC ratio and HC to AC ratio. This is on ultrasonography. Okay, and because sir, the denominator is going to decrease, and numerator is going to remain the same, the ratio will increase. Okay, so basically this is what it is, that abdominal circumference is the best marker, color Doppler is the best investigation, and these two ratios, ratio increase in asymmetric IUGR. This everything is for asymmetric IUGR. Okay. If it is more than one, it is again suggestive of IUG. Okay, clear till now? Okay, now the last part in this is never ever asked color Doppler. Color Doppler is what? It is the blood supply to the baby. Okay, so whenever you know it is what is the next? If I know there is IUGR, if I know there is IUGR, how will I know IUGR? On my clinical examination कि सर height कम है and therefore then I will do ultrasonography to confirm. In USG, what all will I measure? Anybody? Three things: biparietal diameter (BPD), femur length, and abdominal circumference. इसको बोलते हैं fetal biometry also. Okay, so on USG, then you will do this. And if on USG now I know that there is a symmetric IUGR, the next step to be done is, anybody? What is the next step now you will do? ये MCQ आ गया कि patient has come to the OPD at 30 weeks. Clinical examination, baby is only 26 weeks size. And USG confirms. Next step to be done. Wait and watch, time pass, NST, color Doppler, BPP. What's the answer? Yes. Very good. Okay, sir. Whenever I know there is a symmetric IUGR, we will go for color Doppler. Now, please understand one thing. In color Doppler, we study the baby's umbilical artery. Detail you don't have to remember. In the umbilical artery, there is something called as S/D ratio, systolic to diastolic. Remember, higher the D, good for the baby. Higher the D, because baby will get mainly blood during S/D is called systolic to diastolic. Okay, systolic to diastolic ratio in the umbilical artery. How it will look, all that also I'll explain to you. Now, higher the D, good for the baby. So again, when there is IUGR problem, the diastole will decrease. Diastolic flow to the baby will decrease. So can anybody color Doppler of the umbilical artery? Color Doppler is the investigation. Okay, RR. Color Doppler is by sonography only, beta. Okay, color Doppler कैसे करते हैं? This color Doppler, how is it done? Color Doppler is the sonography only. It's a special type of sonography. So simultaneously on USG, now you do, it is called USG color Doppler. Okay, USG color Doppler. Okay, no मिला wrong. 5 to 6 days to terminate तो गलत बात है. Okay, D decreasing नहीं. कभी terminate करना, I will tell you. S/D ratio increase, you can wait for 2 weeks, 3 weeks also, depends. Okay, so color Doppler is a part of sonography only. Okay, is it understood to all of you? So if the denominator is decreasing, again what will happen to the ratio? Ratio increase or decrease? So S/D ratio में क्या होगा? I said that the diastolic flow will decrease. Diastolic flow will decrease. So what will happen to the ratio? Arrow up or yes, very good, RR. That the ratio will, all of you, Sadia, excellent. The ratio will increase. This tells you कि ये कुछ तो गड़बड़ शुरू हो गया है. Are you getting my point? The villain has entered the movie. Ratio has started to increase. No panic. No panic, but you cannot neglect the patient. You need to keep on doing color Doppler. Okay? Now, please understand this. This is like a number. Okay, diastolic ratio is like a number. 5, 4, 3, 2, 1, 0. So as the condition will worsen, you will wait. But now if I come, a day will come when the blood supply diastole 0, absent diastolic flow. Very, very dangerous. Okay, blood supply to the baby stop. And still, if the condition worsens, the blood flow will become negative, reverse. That means, sir, normally the mother's blood goes to the baby. Their baby's blood is coming back to the mother. Common sense, all of you, please tell me, that both these absent flow, reversal of flow, I should do immediate delivery. Why I should do immediate delivery? Common sense, sir. Baby blood supply 0. Baby blood supply reverse. What will next happen? Baby dead. Yes, baby will die. समझ में आ गया? So this reversal of flow is called impending IUFD. When the blood flow is reversed, it is like impending IUFD. Now comes your numbers which you are not supposed to remember. Okay, sir, after absent flow, within 4 to 5 to 7 days, baby can die. They say 7 days, but we don't even wait for 7 days. Okay, so after absent flow, baby can die within 5-6 days. And reversal of flow, to 24 to 48 hours, the baby can die. Are you getting my point? So this is the severity of IUGR. बात समझ में आ रहा है कि सर पहले ब्लड सप्लाई खाली कम हुआ है, देन और IUGR बढ़ते गया, बेबी ब्लड सप्लाई और लेस, एंड देन baby reversal, and then baby dead. And by the way, yes, okay, and by the way, this is not only why immediate delivery, because otherwise the baby will die. And last point, these babies are so small, these babies are so weak inside, because they'll be hardly 1.5 kilo. They will not be able to bear the stress of labor. They will not be able to bear the stress of labor, and therefore I will do immediate LSCS, not only delivery, do a C-section, because these babies will not be able to bear the stress of labor. Are you getting my point? Are you getting my point? Okay. Okay, is this understood to all of you? So now suppose the virginest, ये कोई MCQ नहीं आया है, but just by the way, कि on 34 weeks patient, primi gravida, has come to the OPD. On examination, the size of the baby, she's 34 weeks on. Actually, by her date, she is 34 weeks. But on examination, uterus is only appearing 28 to 30 week size. On ultrasonography, this same. On examination clinically as well as on ultrasonography, the baby has grown only till 28 to 30 weeks. And on color Doppler, there is reversal. This is Virgin 2027 MCQ. On color Doppler, there is reversal of flow in the baby's umbilical artery. Next best step, wait and watch. Repeat color Doppler after 7 days. Immediate LSCS. And tough example, induction of labor. Chalo, anybody wants the answer? Yes, very good, sir. If you wait and watch, the baby will have IUFD. If you repeat after 7 days also, by that time the baby will land up in IUFD, and I have to immediately do the delivery, because this is induction will not. Induction you don't induce at induction of labor, suppose after say after 7 days again. So this is wrong answer. This is the best answer. Okay, yes, because why, sir? There is reversal of flow. Okay, so all this nobody will ask you, but just remember कि पहले umbilical artery में D खाली कम होगा, मतलब रेशियो बढ़ेगा, और कंडीशन वर्सन होगा तो डी एब्सेंट, डिलीवर द बेबी आउट, डी रिवर्स, इमीडिएटली डिलीवर द बेबी आउट. मतलब डोंट इवन वेट टिल दिस 3 and 4, because this 4 will then lead to IUFD. This is impending IUFD. Okay, So all of you please pay attention that a normal, all of you, this again nobody is going to ask you, a normal S by D indicates that the fetus is receiving adequate blood supply. Okay, easy. Rising S by D is the earliest change to happen in IUGR. Virgin MCQ. So now again can you tell me, okay, in a symmetric IUGR, which is the earliest color Doppler changes or color Doppler finding in asymmetric IUGR? Normal S by D ratio, S by D ratio increase, S by D ratio decrease, absent diastolic, absent D, D matlab absent diastolic flow. Anybody what's the answer? Yes, excellent all of you. Okay, sir, normal S by D नहीं होगा. S by D ratio will not decrease. S by D ratio will increase because the diastolic flow will decrease. So S by D ratio will increase and it's like a number. Okay, sir, D is like, it's like a S आपका D. D will keep on becoming less. Example, 5, 4, 3, 2, 1, 0. And then it will go in negative. So absent diastolic flow इसके बाद आएगा. Okay, so all this nobody will ask. Okay, and in absent diastolic flow is a ominous sign or a bad sign, and in extreme cases the blood flow will even become reversed, and that is called as impending IUFD. Is this understood to all of you? Is this understood to all of you? Yes. Now the last part कि अगर ये सब हो रहा है, मैंने आपको क्या कहा था कि 1, 3, 4, तो नंबर 2 क्या है? What is the number 2? Anybody? What is brain sparing effect? What is brain sparing effect in one line? Can anybody tell me? Blood supply to the brain will become more or less? Okay, sir. When this S by D ratio starts to increase, the brain, yes, now the baby will start diverting more blood. Baby will start diverting more blood to the brain, and therefore in the brain we study middle cerebral artery. Middle cerebral artery we study, and in middle cerebral artery the blood supply will increase. Blood supply will increase. That is the brain sparing effect. Clap if you have learned something new. Okay, sir. In fetus with IUGR, as the S by D ratio begins to rise, the blood flow in the MCA will increase. This is the brain sparing effect. Okay, so in all, please understand, all ACA, MC, all cerebral artery, the blood flow will increase, but middle cerebral artery is the one which I study on the color Doppler. Okay, so all this nobody, ये आज तक कभी भी जिंदगी में क्वेश्चन नहीं आए हैं, कोई आपको 5 साल तक क्वेश्चन नहीं आएगा, लेकिन just for my love for completing the topic, and this is how I told you that color Doppler is the most important investigation in management of IUGR. Color Doppler will tell you it's the best investigation for IUGR, because that's what I told you, that color Doppler will tell me when to deliver and how to deliver. So if my S by D ratio is high, you can wait. But then absent flow, do the delivery. Reversal of flow, immediately do the delivery. Okay. So suppose, and if you understand, all of you please pay attention. If you know little bit of mathematics, ये जो मैंने कहा है 1, फिर 2, फिर 3, फिर 4. दिस इज सीक्वेंस ऑफ इवेंट्स. एक ही रिपोर्ट पे all of you please pay attention on one report. D cannot be less also, D cannot be absent also, D cannot be reverse also. Do you agree with me? ये 1, 3, 4 is progression of event. सर पहले S by D ratio बढ़ेगा. So you do every 7 to 10 days. Yes, you have to do sequential color Doppler. Sequential color Doppler मतलब के every 10 days, every 15 days you call the patient for color Doppler. Why? Because we want to wait till we reach that magical number of 37 weeks. Once you reach 37 weeks, you can induce the labor and get the wave. So suppose here, so MCA blood flow is increased. Sir, here I can induce the labor. In MCA blood flow is increased, then I can induce. Ideally, somewhere between 2 and 3. Somewhere between 2 and 3 only induce the labor, get the baby out. But अगर point number 3 आ गया, then LSCS. Point number 4 आ गया तो immediate LS. Because absent flow, reversal of flow, we can do LSCS. Is this understood to all of you? Okay, absent flow, reversal of flow, we can do LSCS directly. Is this understood? So this is, I repeat for the last time, this is sequence of events. एक ही रिपोर्ट पे आपका D कम नहीं होगा, जीरो नहीं होगा और रिवर्स नहीं होगा. पहले D कम होगा. So you will say, okay, I will have to keep you under check. Come back, but don't come back after 6 months. Come back after 7 days, 15 days, come back to the OPD for color Doppler. फिर आपको पता चला D और कम हो रहा है, okay, no problem. And जैसे पता चला D कम है, D zero है, please admit and do C-section. Is this understood to all of you? Yes. So this is how there is sequence of events. Okay, first there is the S by D ratio normal, means it is very good. S by D ratio rising is the earliest change. And then absent flow is a bad sign and reversal of flow is the impending IUFD. We should directly go and do LSCS. Absent flow also please do directly LSCS. Is this clear to all of you? Of course, steroids you will give. Steroids can be given for lung maturity. It is understood. Okay, if we are 32, 33 weeks, the steroids will be given and then I do LSCS. Is this understood to all of you? And the last thing we told you that in IUGR as the S-body ratio begins to rise, the blood flow in the MCA increases. This is the brain sparing effect. Okay, this is the baby's way to do a compensation. Okay, this is baby's mechanism for compensation. Okay, so now all of you pay attention. Again, Virgin MCQ, Virgin 2027 MCQ के कैसे होता है on color Doppler? Color Doppler, this is how the wave looks like. ये systolic wave and ये diastolic wave. तो इसको बोलते हैं S and इसको बोलते हैं D. So the D has got a good length. ये length अच्छा है. ओके, वो हर वीक्स के हिसाब से नॉर्मल लेंथ डिसाइड होता है कि डी का जो हाइट है इज गुड. नाउ सपोज सो दिस इज लाइक नॉर्मल. नाउ ऑल ऑफ यू टेल मी, सपोज पीजी लेवल, ये दिस ऑन कलर डॉपलर, ये कलर डॉपलर वेव आई एम शोइंग यू. ऑन कलर डॉपलर सपोज आपका एस आ गया ये, बट नाउ डी आ गया ये. व्हाट इज दिस एनीबडी? व्हाट इज दिस? What is this stage? Even by looking at it, you will come to know. Okay, this D wave should be like this. Now this D wave is only this much. Yes. Okay, sir, this is a stage where the D has decreased. S has remained the same. Yes, one of the earliest sign of IUGR. And on color Doppler, the D is, yeah, asymmetric is understood. Asymmetric का ही बात हो रहा है. But this is a stage where the D has decreased. So the S by D ratio is increasing. This is the first stage. ये वाले का picture. Okay, ये वाले का picture. Rising S by D. Okay, and suppose more days, 7 days, 10 days, 15 days gone, and then only systolic wave. What is this? What is this? This is the absent diastolic flow. Excellent, all of you. And lastly, the D can even go below. D can even go below. This is D is reversed. Okay, I hope all of you can. I'll just move out because thoda hai. Okay, so all of you can read. Okay, so this is D has become reverse. Yes. So all of you, this is what it is, that nobody will ask you all this. ये कोई नहीं पूछेगा कि sir in this is a normal S by D कि D को भी length है. Now if you see over here, S is okay, but the D is less, reduced and diastolic, so D has become lesser. And then you can see, sir, only S wave, absent D. And lastly, you can see that this D is going below the baseline, so reversal of flow. Okay, so nobody is going to ask you all this, but this is just to explain to you the meaning. And the last part, this is the actual picture. अभी इसमें देखो normal, okay? इसमें देखेंगे actual picture. Okay, sir, S is like this and D is like this. Very good. Systolic wave, diastolic wave. Systolic wave, diastolic wave. So D को अच्छा length है. So see, this is USG only. Can you see, all of you students? This is on ultrasonography only. We are doing color Doppler. It's called USG color Doppler. Okay. Okay, and now all of you look on the board. Can you see this part? Can you see the upper wave? Upper wave क्या है? Upper में क्या है? खाली आपको systolic wave, only systolic wave. Can you see? There is no diastolic wave. That's called absent and diastolic flow. Okay, and last part, yes, only S, yes, absolutely. And last में देखोगे कि ये देखो D सब नीचे जा रहा है बेसमेंट बेसलाइन के, मतलब के D is reversed. Is this understood? All this, my dear students, will come in next level. 2027 के पहले कोई नहीं आने वाला है. Nobody will teach you all this, is my guarantee. Ask all your friends, those who have not attended my lecture, they will not even heard about all this thing, and no other coaching class में कोई सिखाते भी नहीं है कि absent flow, reversal of flow, is my guarantee. Okay, so this, you don't have to get too much worried. You just have to remember, okay, yes, this is the absent flow and this is the reversal of flow. Okay, this is the reversal of flow. This is how the things are. And just remember, okay, just you have to remember that absent flow, reversal of flow, I have to do immediate delivery and immediate LSCS. Why? Otherwise the baby will die. Common sense, no? Baby blood supply stop, baby blood supply reverse, baby will then die. So a reversal of flow is like impending IUFD. Okay, impending IUFD. So all these are the reversal of diastolic flow, beta. Whenever it will happen, let it be 30 weeks, 32, that depends on severe. You have to do LSCS only because the baby will die. So yes, these babies will require good NICU. So suppose you are correct, all of you pay attention. What Bilal is trying to tell me, that sir, we had a patient जिसको suppose 24 weeks पे very severe problem, 24 weeks ही था बेबी को, and baby was just some 500-600 grams, and your S by D ratio में D हो गया reverse. Sorry, we are not God. This baby did not survive. this baby landed up with baby died. Because 500 gram baby, how will the baby survive? Okay, but similarly, अगर 30 भी होने दो, 32 भी होने दो, 34, if the baby is 1 kilo, 1 kilo, 1.5 kilo, then I can definitely save the baby by doing LSCS. At least you try, because otherwise, and if it's a D is reverse. Okay, so all this, because if you don't, you can't wait. Okay, all of you tell me, think logic. Okay, sir, suppose 32 weeks pay, we are only 32 weeks. I agree with all of you. And there is reversal of flow. Can you tell me, okay, chalo, no, sir, we are only 32 weeks. Let me wait till 36 weeks. Possible hai? Not possible, isn't it? If I wait till 36 weeks, क्या हो जाने वाला है? IUFD. So let it be 32 weeks reversal of flow. It is immediate LSCS. Okay. Is this understood to all of you? Yes, Bilal. So let the reversal of flow be at 32 weeks. Yes, the best scenario is कि reversal of flow तक होगा ही नहीं. The best case is कि sir, we are 37 weeks. We are 37 weeks and S by D is normal. Then I will induce the labor and get the baby out, because we have reached 37 weeks. Or sir, we are 37 weeks and S by D has only started to increase. That means we are at early stage, but we have reached 37 weeks. So then it will be induction of labor. So all this is PG level. Okay. Are you getting my point? Okay, sir, reversal of flow है 32 weeks पे तो section कर दो, and 37 weeks पे S by D ratio ज़्यादा तो we can only induce the labor. Induce the labor and try for vaginal delivery. Okay, otherwise even LSCS you can do if the baby is very small. Okay, so all this they will not ask you. You just have to remember that absent flow, reversal of flow is an indication for LSCS, whatever may be the weeks of gestation. Okay, because otherwise the baby will land up with LSCS. Induction of labor, beta, forget it. RR. Induction of labor means you can try LSCS. Instead of LSCS, you can induce labor, na? You will induce the labor when you reach 37 weeks. If you reach 37 weeks, there's no, once you reach 37 weeks, you can induce the labor. Okay, and get the baby out. But you can induce the labor when only S by D ratio has just increased. Is it clear? RR. If at 37 weeks also, if they tell you that it is absent flow, reversal of flow, we should directly do LSCS only. So, but all these questions have never been asked to you. You just don't get into the hassle of all this ESF. ESF is this PG level. You just remember absent flow, reversal of flow. The baby is very, very weak inside. It is an impending IUFD, and therefore we should do immediate LSCS. Let this be 34 weeks. Let this be 32 weeks. Let this be 36 weeks. Let this be 28 weeks. Let this be 30 weeks. Okay. 28, 30, 34 weeks है, reversal of flow है, you will not wait, you will do LSCS because it is impending IU. Why? Because the reversal of flow is telling you impending IUFD. Okay, moving on to the next very, very important topic, and that is the topic of RH negative pregnancy. That is understood better. That magnesium sulfate you will give, steroids you will give, very good. All that is understood. For neuroprotection you can give before LSCS planning, very good, Bilal. So if I know that I'm going to do LSCS tomorrow, today I can give her that neuroprotection ke liye MgSO4. Okay. Yes. Next. Yeah. Okay. Now, very, very rarely asked topic. Occasionally only the question has come. But the problem is that students do not know much about this. And what is this topic is RH negative. Now, in the whole story in RH negative, the mother is RH negative blood group. And the father or the husband both mean the same thing, is RH positive. Both are RH negative, no problem. Husband, wife, both are Rh negative, no problem. The problem happens when the mother is Rh negative and the father is Rh positive. Anybody, what can happen? What can happen? Okay. What can happen is that the baby again, if the baby is Rh negative, no tension. Suppose the baby is Rh negative, no tension. Okay. But suppose the baby is Rh positive. Yes. Suppose the baby is Rh positive. Then the Rh positive cells from the baby can enter into the mother. Okay. Rh positive cells from the baby can enter into the mother. This is called as feto-maternal hemorrhage. I repeat, the baby ka Rh positive cells can leak into the mother. Some Rh positive cells can leak into the mother. This is called as feto-maternal hemorrhage. I'll show you the full form in the next slide. FMH, feto-maternal hemorrhage. तो क्या होगा कि if this Rh positive cells enter into the Rh negative mother, this Rh negative mother will form the antibody. And this antibody, once it is formed, जिंदगी भर मदर का ब्लड में रहेगा. I repeat, once the antibody is already present, then nothing can be done. It will remain in the mother's blood. And in the next pregnancy, because the first baby, generally I'll explain to you why the first baby escapes. Okay. So the feto-maternal hemorrhage will cause the antibody to leak, will cause the antibody formation. And now this antibody will do what? Anybody? What will the antibody do? What will this antibody do? चलो, ये antibody बन गया. Antibody against the Rh positive cells. हाँ, not kill the next baby बेटा. RR kill तो बहुत ले. Why? It will not always kill. It will basically start causing, yes, it will cause fetal hemolysis. Fetal hemolysis. So basically when the baby will be there inside, the baby blood will keep on, yes, it will cause complication for the next pregnancy, correct? That is true. Next time the antibody is present. So it will keep on doing fetal hemolysis. So क्या होता है? Because antibody का titer हमेशा बढ़ते जाएगा. All of you know, antibody titer will keep on increasing. And therefore, baby will have severe anemia, then jaundice, then hydrops. What is hydrops? Fetal hemolysis पहले होगा. मतलब in short, there is nothing but fetal anemia. This is in nutshell the whole story. This is in nutshell the trailer of the picture. These are Rh positive cells from the baby enter into the mother. Mother forms the antibody, and antibody will then cross the placenta. Which antibody? All that we'll discuss. Okay. IgM is formed in IgG crosses the placenta, and then antibody will cause the baby to hemoglobin to become less. And then what can happen is that when there is fetal anemia, there is baby will go in congestive cardiac failure, and that will then cause the baby to become hydrops. What is fetal hydrops? Anybody? Hydrops मतलब water everywhere, not a drop to drink. मतलब के सर बेबी के अंदर सब जगह सब पानी हो गया. What is the meaning of hydrops? सर सब पानी हो गया. मतलब inside the baby ascites, pericardial effusion, pleural effusion, scalp edema, placenta is edema, there is polyhydramnios. Yes, everywhere fluid in the baby body. That is because the baby is in congestive cardiac failure. The baby is in congestive cardiac failure. So baby is in cardiac failure because of severe fetal anemia. And then there will be fetal hydrops, and then of course baby can die. Okay. So now what, as you rightly said, anybody, can you tell me, antibody keeps on increasing in titer. तो उससे क्या होगा, कैन यू टेल मी, इफ आई टेल यू दैट द आउटकम विल वर्सन with every pregnancy, or outcome will improve with every pregnancy? क्या होगा? कॉमन सेंस, थिंक, लॉजिक. ऑप्शन ए होगा कि ऑप्शन बी होगा इन आर एच नेगेटिव? In RH, iso, I'll tell you, this is called isoimmunization. This phenomenon, this mother is now antibody ban gaya. This is called, very good, very good. This is RH, isoimmunized. Yes, sir. Outcome worsens with every pregnancy. That means what? All of you pay attention. Okay, sir, what will happen? इसका मतलब what will happen? All of you pay attention. Okay, sir, the first baby generally is unaffected. The next baby will have severe anemia at birth. जब बेबी बॉर्न होगा सीवियर अनीमिया होगा नेक्स्ट बेबी को. नेक्स्ट में क्या हो जाएगा? सीवियर अनीमिया एट 37 वीक्स, डिलीवरी के पहले ही. थर्ड बेबी सीवियर अनीमिया एंड देन हाइड्रॉप्स एट 34 वीक्स ओनली. समझ में आ गया? नेक्स्ट बेबी सीवियर हाइड्रॉप्स एट 28 वीक्स ओनली. ये समझ में आ रहा आप लोगों को? यस. कि सर फर्स्ट बेबी को प्रॉब्लम, फर्स्ट बेबी को जनरली नहीं प्रॉब्लम, बट नाउ द फर्स्ट अफेक्टेड बेबी को जस्ट एट बर्थ थोड़ा माइल्ड प्रॉब्लम. Yes, we'll discuss that. Yes, first baby generally will be normal. By this first, I mean the first affected baby. Okay, so first baby is generally normal. Why? I'll also explain. First baby escapes. Why? Okay, so this is the first affected baby, anemia at birth. Then anemia and hydrops at 37, then 34, then 20. आपको समझ में आ रहा है? This is to tell you that the outcome worsens with every pregnancy. Okay. Now, virgin MCQ, virgin MCQ. ये सब जो पूरा स्टोरी विच आई टोल्ड यू, हाँ, वाई फर्स्ट बेबी विल डिस्कस ना, यू ओनली टेल मी वाई फर्स्ट बेबी विल एस्केप. ओके, सो ये सब जो पूरा स्टोरी है, दिस होल स्टोरी विच इज ऑन द बोर्ड, कि सर द RH पॉजिटिव बेबी, RH पॉजिटिव baby will leak some cells into the mother. Mother will, so mother, this is called mother will form antibody. This is called isoimmunization. मतलब mother is isoimmunized because mother has formed antibody for its own baby. So it's called isoimmunization. And now the antibody will increase. So my first question to all of you is, how much blood from the baby, if it enters into the mother, this whole story will start. FMH is feto-maternal hemorrhage. So if I ask you what is the critical amount, virgin MCQ, critical amount of feto-maternal hemorrhage. Any idea? कितना ब्लड बेबी में से मदर में जाएगा तो ये सब प्रॉब्लम स्टार्ट होगा? 5 ml, 20 ml, 30 ml, 100 ml, 0.1 ml, 0.5 ml. Yes, even 0.1 ml, even 0.1 ml. If the this is now समझ में आ गया जो पूछा FMH क्या है? Feto maternal hemorrhage. The critical amount, that is the fetal blood required to stimulate the mother antibody process, 0.1 ml. Okay. Now, antibodies are IgG and IgM. IgG crosses the placenta and causes fetal hemolysis, and outcome worsens with every pregnancy because the antibody titer will keep on increasing. That means our first baby will have no problem at all. Second baby will have only problem after delivery. Third baby will have problem at 36 weeks, then 34 weeks, then 28 weeks, like that. Now coming to the question, why the first baby escapes? Anybody? Why the first baby escapes? Okay, so this is your, then the immune hydrops is abnormal collection of fluid in the baby in more than one space, like example ascites, pleural effusion, okay, even scalp edema. And anybody, there is, why is it called, what is scalp edema called as? Scalp edema se kya hoga? We will discuss this on the baby. Anybody, what is it called as? Okay, yes. So Chetna, yes, that is correct. कि सर ये जो फर्स्ट पार्ट, कि ये जो फीटो मैटरनल हेमरेज होता है, that mainly happens at the time of delivery. So the first baby तो निकल गया, लेकिन वो पीछे वाले का सबका वाट लगा के जाता है. So first baby, the first baby at the time of delivery will leak some feto-maternal cells, will leak the Rh positive cells. So first baby तो निकल गया, but वो जाते जाते बाकी सबका वाट लगा के जाता है. और अगर so majority, mostly at delivery. But by chance sir, कभी तो feto maternal hemorrhage हो गया at 28 weeks, 30 weeks, 32 weeks, yes, हो सकता है. But therefore the antibody titer, and suppose the fetal hemorrhage happens during pregnancy, then the antibody titer is very low. Okay, starting में just when there is first immune response, the titer is very low. So most, there are two reasons कि sir most, और आप यही याद रखो कि sir mostly the FMH happens at the time of delivery. Mostly the FMH happens at the time of delivery, so the first baby escapes. But by chance, if the FMH happens even during pregnancy, the antibody is in very low titer. But now second time the antibody एकदम ready बैठा है. Second time the antibody is extremely ready, and now even if little bit hemorrhage, there's a peak antibody response. Okay, so antibody titer is low, but it will keep on increasing in titer. Okay, is this understood to all of you? Now, can anybody tell me what is Buddha sign? Buddha sign seen in Virgin MCQ. Buddha sign seen in what? Yes, but Gopinath, scalp edema. Okay, when there is scalp edema, okay, as I told you, Buddha sign, yes, Buddha sign is in hydrops, but where exactly? Okay, sir, ये baby का head होता है, like how Gautam Buddha, बेसिकली महावीर भगवान हैड अ हेलो. अगर आपने कभी भगवान का फोटो देखा है महावीर भगवान का, बुद्ध भगवान का, महावीर बुद्ध भगवान, देयर इज ऑलवेज अ हेलो. सो दिस Bhagwan, because when Gautam Buddha attained a nirvana, there was a halo around the god. So same thing hai कि this is the baby head and this is actually the edema fluid, and therefore वो scalp will look like this Buddha sign is seen in. Yes, hydrops, I agree with all of you, but what is it indicating? It is indicating scalp edema. Clap if you have learned something new. Okay. Okay. Okay, yes. So this is the scalp edema and this is the Buddha sign. Scalp edema, but हाँ scalp. Skin edema भी होगा, skin में भी, everywhere there will be edema. Skin edema less होता है. Basically fluid will get collected everywhere. Okay. So क्या क्या होगा? If I look at the hydrops fetalis, yes, placentomegaly, very good. Okay. So there will be ground glass placenta. Placenta itself will be bigger. Okay. So placenta will be bigger. Then there will be pericardial effusion, pleural effusion, ascites, and scalp edema, which is the Buddha sign. Last, you please wait. I'll explain to you in some time. Okay, so these are the USG findings in hydro. Basically, everywhere सब पानी पानी हो गया. आपको खाली दो ही याद रखना है. Pericardial. You have to just remember points B and C. Pleural effusion, ascites, pericardial effusion. Okay, and scalp edema, Buddha sign. Okay, now please pay attention. So point number 1, outcome worsens with every pregnancy. Outcome will cause fetal hydrops and hydrops में ये सब changes होगा. Now, anybody, first of all, the anti-D injection. We will discuss when to give, when not to give. Okay, the anti-D injection, can all of you tell me, which I give to mother, what does it do? What is the role of the anti-D injection? Anti-D क्या करता है? Anti-D, when I give to mother, anti-D is given to mother, it will coat the fetal RBC. ये fetal RBC है. These are RH positive fetal RBC. Very good RR, excellent answer. It will prevent the antibody formation. But now tell me this also. Suppose the antigen, so this is the antigen, this already goes and stimulates the mother immune system, and suppose mother has now formed the antibody. Okay, antibody picture में आ गया. Villain has entered the movie. Villain has now entered the movie. तो anti-D का क्या role है? Anybody? What will the anti-D do now? Or can it do something, or it cannot do anything? Okay. RR is saying no role, antibody already present. Okay. Anyone else? I repeat my question. Okay, the anti-D role, all of you pay attention. Anti-D role is to coat the fetal RBC and prevent them from stimulating the mother, and therefore prevent the antibody formation. That everybody knows. So anti-D is to prevent the antibody formation. When do you give it? All that we'll discuss. Okay, when to give it, even during first. Okay, anti-D role is to prevent the antibody formation. I agree with all of you. But suppose if the antibody is already present, तो फिर anti-D क्या करेगा? Can it neutralize the antibody? Okay, so please understand this. Many students have this misconception that if the antibody is present, anti-D can still neutralize the antibody. Sorry, I want you to write down this word. Okay, sir, if the antibody is already present, anti-D is useless. Useless. Matlab, absolutely there is no role of giving anti-D. Is this understood to all of you? Clap if you have learned something new. That means, sir, the anti-D will coat the fetal RBC and will act like a policeman and stop this antigen from reaching the mother. But if the mother, somehow the fetal RBC leak and the mother has already formed the antibody, now the anti-D, no role, no role. Is this understood to all of you? When the antibody are already present, then anti-D has got no role. Is this clear to all of you? I want 10 thumbs up, then I'll proceed further. Okay, sir, now the antibody is useless. Write down, sorry, now the anti-D is useless. Okay. Now the antibody एक बार बन गया, जिंदगी भर रहेगा. Now the anti-D has got no role, no point in giving anti-D injection. Okay, ये basic concept है which many of the students don't know. Now see how do we manage. This is very, very interesting, and then I discuss the anti-D doses and how much you give and all that. Okay. So whenever so you know this, first you know कितना ml of blood गया, 0.1 ml तो problem हो गया. Basically it is not, this whole story is nothing but fetal hemolysis. So basically it is nothing but fetal anemia. It is simple, in simplest form, it is nothing but fetal anemia. Fetal hemoglobin is becoming 15, 14, 10, 9, 8, 7. Okay, and high drops. So this is nothing but, in short, it is the fetal anemia because of this Rh antibody, and outcome will worsen with every pregnancy because the antibody titer keeps on increasing and the first baby generally escapes. Okay, and these are the findings of hydro. Last line, I'm coming to it in a minute. Okay, what is it? I'll explain to you in a minute. Now, an anti-D role is to prevent. Okay, so all of you pay attention. I'm just coming to this in a minute. I'm just coming to the first 2 points. But when the mother is already sensitized, there is no role of anti-D. Okay, is this understood to all of you? Anti-D is useless. If the mother is already sensitized, please write down useless word, because when you write the word useless, you will remember. Okay. Okay, there's no role for anti-D. Now all of you pay attention. Okay, now all of you pay attention. Okay, sir, when I have a mother who is Rh negative, mother is Rh negative, father is Rh positive. During the pregnancy, we do ICT, indirect Coombs test. Okay, we do indirect Coombs test, ICT. ICT should remain negative lifelong. Simple, yaad rakho. If anybody is Rh negative, ICD should remain negative. ICT is what? Indirect Coombs test. Okay, that they will teach you in micro and patho. And DCT is done by the pediatrician on the baby. Okay, so direct Coombs test I do for the baby. In mothers, I do ICT, indirect Coombs test. So ICT should remain negative. Anybody? ICT negative होना चाहिए lifelong. If anytime ICT becomes positive, any idea? ICT positive means what? If on the mother, if Rh negative mother, I get that the ICT is positive. Give entity wrong, beta Bilal. Kachra, dustbin answer. Okay. ICT positive means what? Yes. ICT positive मतलब के ये जो पूरा स्टोरी ICT positive matlab antibody has now entered the movie. Is this clear to all of you? कि this antibody आ गया, I come to know. Yes, very good. Okay, so now ICT will become positive. ICT positive, no, I know. Okay, anti-D has got no role. Yes, already the anti-D. मतलब basically antibody has entered the movie. बस उतना याद रखो कि सर ICT positive मतलब के the villain has entered the movie. So I need to do that RH titer and we see कि कितना level of antibody है. You do the RH titer. And now there is some critical level. Forget all that also I'll discuss. Now if the RH titer is above the critical level, okay, now what do you do? ध्यान से सुनो. All this nobody is going to ask you. Only for my love for the subject I am teaching you. These questions has come only once in the toughest All India exam. I'll tell you which was the toughest MCQ. I repeat, for this topic nobody teaches you. I'm going very slow. Okay, sir, when the ICT is positive, it means that now the antibody is present. Antibody is now present. Antibody has entered the movie. So of course it is crossing the placenta. Yes, it is causing the fetal hemolysis. So what I need to find out, I need to find out how much is the fetal hemolysis happening. That I need to find out. Okay, how much is the fetal hemolysis happening? That I need to find out. So here now we have got two options. One is the old approach, which we don't do, but for MCQ we should know. And one is the new or the modern approach, what we do, and this is a virgin MCQ. So old approach में हम करते हैं amniocentesis and new approach में हम करते हैं color Doppler. All this I'll explain to you in the next 10 minutes. Don't worry. अभी खाली सुनते जाओ. Okay, I repeat that when the RH titer is above, its RH titer is positive and it is above the critical level, we have got two options. What are the two options? Sir, one is amniocentesis and second is the color Doppler. Because what are we worried about? We want to check कि कितना fetal hemolysis हो रहा है, बराबर ना? Because ये antibody अगर है तो वो खाली मदर में थोड़ी रहेगा. It's going to cross the placenta. Antibody will then cross the placenta and do what? Anybody? Antibody will cross the placenta and do what? It will start doing fetal hemolysis. Common sense. Antibody तो अपना attack करेगा. Okay. So obviously anti-D has got no role now. So now what do you do? Yes, it is causing fetal hemolysis. Very good. So now I want to know how much is the hemolysis, like mild, moderate, severe. So here I take a needle, puncture the uterus, take the amniotic fluid out. We do the amniocentesis, take the amniotic fluid out, and that amniotic fluid I expose to photospectrometry, जो हम biochemistry में first year में करते हैं. Forget all this, and you expose that amniotic fluid to photospectrometry 450 nanometer wavelength. Forget all this. Many of you might be hearing it for the first time, all this thing, and I get a value called as delta 450. मतलब at 450 nanometer wavelength optical density, we get a value called as delta 450. Now this delta 450 is plotted on whose chart? Anybody? Have you heard this name before? Lily's chart. Lily's chart और Lily's chart में plot करना है. Don't worry, all these questions have not been asked to you ever. And this Lily's chart has got zone 1, zone 2, zone 3. This is the Lily's chart or the Lily's chart. Simple logic. Zone 1 is mild hemolysis. Zone 2 is moderate hemolysis. Zone 3 is severe hemolysis. So zone 1, wait and watch. Zone 2, again wait and watch. But now my question to all of you is, what will I do if the delta, this is the delta 450 value. Okay, so don't worry. They will not ask you all. They will just tell you delta 450 value is in zone 3. What to do? Now my question to all of you. Can anybody tell me if the delta 450 value is in zone 3? Okay, if this delta 450 value is in zone 3, what does it indicate? Anybody? It indicates severe hemolysis. So suppose if the pregnancy is already more than 34 weeks, here you don't even wait till 37 weeks. If the pregnancy is 34, 35 weeks in the question paper, we will do the delivery. Okay, because otherwise the baby will keep on getting not necessary LSCs directly, but induce the labor and basically get the baby out, induction of labor or LSCs, but do the delivery. Okay, but that is not the question. The question for all of you is, sir, the delta 450 value is in zone 3 and the pregnancy is less than 34 weeks. And by less than 34 weeks, I don't mean 33 weeks and 6 days. Say example, pregnancy is 28 weeks, 30 weeks. So what will I do? Anybody? What will I do? Okay. Okay. So point number 1, simple logic. This was the toughest MCQ ever asked in the NEET PG till now, according to me. In the, no, if it's less than 34 weeks, what? If it's more than 34 weeks, I do the delivery. Very good. Now here what I do. Dhyan se suno. Okay. If the pregnancy is less than 34 weeks, basically what does zone 3 tell you? Zone 3 is telling you what? Zone 3 is telling you severe hemolysis. So if you have severe blood loss, what you require? You require blood. So here we do a super sophisticated procedure where inside the uterus, the baby is inside the uterus and I give fresh O negative blood to the baby. That is called as intrauterine transfusion. Only once in the whole India exam, only once this question has come, the toughest MCQ ever. Okay, what will I do if the delta 450 is in zone 3 and pregnancy is less than 34 weeks? Sir, intrauterine transfusion. Don't use the word exchange transfusion, because ऑप्शन में आपके पास दोनों ऑप्शन होगा. Now tell me the answer. Patient is 34-year-old patient, RH negative, 28 weeks. 28 weeks ICT is plus and the ICT is plus. So the amniocentesis is done. Amniocentesis में the delta 450 value comes in zone 3 of the Lily's chart. What next? Repeat amnio after 7 days. Induction of labor. Tell me the answer. Don't worry, I'll repeat all this in some time. Very good. Sir, if I repeat, After 7 days it will be too late. Sir, basically zone 3 matlab baby hemoglobin is very low. It's like hemoglobin is dropping down. 5 4 3 2 1 baby, this will be hydrops. The baby will be in hydrops because zone 3 is telling you it is severe hemolysis. So I will exchange transfusion is done by the pediatrician on the baby after baby delivery. IUT का मतलब है, please understand this done at very few places. Okay, IUT is IUT, but I'll tell you, ऋषि पहले ये ध्यान से सुनो. Okay, IUT is done at only few centers all over India, where under sonography guidance, you puncture the baby umbilical vein and give baby blood. Basically, baby को blood देना है. That is called as intrauterine transfusion. And it's like magic. What will happen when you give blood to the baby? What will happen? Baby hemoglobin will start increasing. Say hemoglobin was 7, it will become 8, 9, 10. All the hydrops will start disappearing. Baby will start looking better. Edema कम हो जाएगा, fluid कम हो जाएगा, and baby starts looking better. Okay, hydrops will reverse. This is a reversible hydrops. Okay, लेकिन all of you please pay attention. Is that antibody over? नहीं, एंटीबॉडी तो अभी भी प्लासेंटा क्रॉस कर रहा है. एंटीबॉडी विल ओनली स्टॉप व्हेन आई कट द कॉर्ड. बराबर ना? व्हेन विल एंटीबॉडी स्टॉप गोइंग टू द बेबी? व्हेन डज द एंटीबॉडी स्टॉप गोइंग टू द बेबी? एट द टाइम ऑफ डिलीवरी व्हेन आई क्लैम्प द कॉर्ड. बराबर? Only at the time of delivery when I clamp the cord, the antibody will stop going to the baby. So generally, one IUT is required for 7 to 10 days, sufficient for 7 to 10 days. It is like the situation, if you understand, कि sir on one side I am giving you blood, आप सबके लिए ये situation है कि sir on one side I am giving you blood, but on one side you also have a cut. So हमने blood दिया लेकिन यहाँ पे cut भी है, तो blood आपको मिला लेकिन ये blood cut blood और कम होने वाला है. तो after 7 days we again repeat the amnio. Okay, we again repeat the amnio, intrauterine transfusion. Okay, so inside the vein we give, artery also you can cannulate, but in the vein we give. Okay, so we cannulate the we after 7 days we repeat the peritoneal bhi hota hai beta. We can give it inside the umbilical cord, or we can also give it below the liver also. Wahan se bhi, from the peritoneum also baby will get the blood. Okay, so we will inside the ductus venosus also you can give. Okay, so now all of you pay attention that you will after 7 days repeat the amnio, and again zone 3, again one IUT. Can anybody tell me what is the role of IUT? Sir, IUT is only temporary, so that my this baby which is 28-30 weeks, वो बढ़ते at least 34 weeks तक pregnancy हो जाएगा, whereby then I can do the delivery. So IUT generally every week one IUT is required. So depending on how much is the severe problem and how early the problem has started. This is the 5-star slide, virgin slide for all of you. Please remember this slide. That sir, if the delta 450 value is in zone 3 indicates what? Sir, it indicates severe hemolysis. And therefore, if the pregnancy is more than 34 weeks in the question paper, better to do the delivery. But if the pregnancy is less than 34 weeks, and by less than 34 weeks, I mean say we are only 26 weeks, 28 weeks, 30 weeks, then I will give IUT. Please draw 5 stars around this. IUT, you will give till you reach 34 weeks, because then it is better, because 32 weeks baby may not survive. Okay, why 34 weeks you have selected? Because sir, after 34 weeks the baby can be saved by the NICU. So you keep on giving IUT till 34 weeks and then you will do the delivery. Is this understood to all of you? 10 thumbs up if you have learned something new. Okay, आपको ये सब कोई नहीं पूछने वाला है, आपको खाली याद रखना है कि जोन 3 मीन्स सीवियर हीमोलिसिस। अगर आपको सीवियर हीमोलिसिस है, आपको भी ब्लड लगेगा, तो ये बेबी को ब्लड देना है, विच इज इंट्रा यूट्राइन ट्रांसफ्यूजन. ओके, वेयर यू गिव बेबी द ब्लड and you keep on giving blood till 34 weeks and then you do the delivery. Okay, now somebody was asking me, okay, sir, what do I do if first only forget? Okay, so first all of you look over here. Okay, okay, sir, whenever the mother is RH pregnant lady and her ICT is positive, then I do the antibody titer. And if the antibody titer is below the critical level, so nothing to it. The antibody is very low amount. It will not cause damage to the baby. So forget this part. Okay. Okay, so the antibody is below the critical titer, कुछ नहीं करना है. And now if the antibody titer is on the higher side, then I will do the amniocentesis on Lily's chart, zone 1. Somebody asked me, sir, receiver, zone 1, you can repeat amnio after 3 weeks. Just wait. Okay, because zone 1 is very mild hemolysis. So zone 1, you repeat the amniocentesis. Zone 2, again you repeat the amniocentesis after only 1 week. But zone 3 is the MCQ. Okay, sir, zone 3, if the pregnancy is more than 34 weeks, what I do? Delivery. And if the pregnancy is less than 34 weeks, this is the answer, IUT. Is this understood to all of you? Nobody must have taught you all this point in your life is my guarantee. Okay, now सर इसमें प्रॉब्लम क्या है कि सर एवरी टाइम आई हैव टू पंक्चर द एब्डोमेन, yes or no? Every time I have to do amnio. So this is a invasive procedure. So sir, can we do something without amnio where I can come to know baby is requiring blood or not? Yes sir, I will go by doing color Doppler. Now color Doppler, the same color Doppler जो हमने अभी IUGR में किया, सिंपल है लॉजिक. If your blood is thin, will it go very slow or it will go very fast in the body? If your blood is very thin, कोई भी thin पानी, एक बाजू एकदम thick घी या घी है तेल है, उसको आप डालो, और एक बाजू क्लियर पानी है, who will go fast? Who will run fast? Yes, thin one. Thin blood will go fast. And therefore, in the color Doppler, we look at peak systolic velocity. All this nobody will ask you in the middle cerebral artery. In the baby middle cerebral artery, you check the baby ka speed, peak systolic, I'm telling you the full form, PSV, peak systolic velocity. If it is normal, very good, nothing to be done. But if it is going at a very fast pace, more than 1.5 times normal, then again it tells you that this is severe hemolysis and again I need to give blood. That means what is this? I was telling you this, okay, when there is severe hydrops, in severe cases, peak systolic velocity in the middle cerebral artery will be more than 1.5 times the normal. Okay, MOM is multiples of median, वो forget it. MOM मतलब multiples of median, मतलब more than 1.5 times the normal आप पकड़ लो. MOM is like another word for normal. So more than 1.5 times the normal, then it is telling you if the peak systolic velocity is more than 1.5 times the MOM, it again tells you that there is severe hemolysis. hemolysis. सो कुछ नहीं करना है आपको कुछ नहीं करना है, आपको सिंपल एक ही चीज करना है कि इन दिस फ्लो चार्ट replace this delta 450 zone 3, you replace it by peak systolic velocity in the middle cerebral artery more than 1.5 times the normal. And baki ka flowchart, clap if you feel happy. It's the same flowchart. Okay, sir. Now, if my pregnancy is more than 34 weeks, I will do the delivery. And pregnancy is less than 34 weeks, I will give intrauterine transfusion. Because zone 3 on Lilly's is corresponding to middle cerebral artery more than 1.5 peak systolic velocity. Okay, sir, in the baby's brain, you check the color. So every time, what is the advantage? Sir, I don't have to do amnio. Isn't it? Amnio में हर time needle poke करना पड़ता है, amniotic fluid देखना पड़ता है, and then decide. Here, without doing amnio, is this understood to all of you? So ये जो मैंने आपको बताया था कि delta 450 can also be replaced. Delta 450 के बदले I can do the exact same flow chart. What is the flow chart? Delta 450 zone 3 के बदले what can I write? I can write, sir, peak systolic velocity in the middle cerebral artery more than 1.5 times the normal. Same. Clap if you feel happy. Same flow chart. Okay, now if they tell you this is your 2030 में ये MCQ आएगा. Okay, on the color Doppler, on the baby middle cerebral artery, the blood flow is going at more than 1.5 times the normal, and we are only 28 to 30 weeks. Answer is IUT. Or sir, we have already 35, 36 weeks. Then better to do the delivery. Okay, is this understood to all of you? Yes. So zone 3, which is telling me severe hemolysis on Lilly's chart, also corresponds to middle cerebral artery peak systolic velocity on color Doppler, which is more than 1.5 times MOM. This is also telling you severe hemolysis. And the management is cut, copy, paste, same. So either we go for delta 450 value and we go for Lilly's chart in the old approach, and in the modern approach, I do color Doppler. That's it. Simple. Thoko tali. Same flow chart. Exactly cut, copy, paste. Same flow chart. जो था. Same flow chart. Okay, sir, when the antibody is positive and antibody is above the critical titer, rather than doing amniocentesis, हम क्या करेंगे? I will do ultrasonography color Doppler of the middle cerebral artery. And if it is less than 1.5 MOM, wait and watch. Sequential. Call the patient again after 7 days, 10 days. Every 7 to 10 days, you can do the color Doppler because it is less than 1.5. So wait and watch. Okay, less than 1.5, wait and watch. And if it is more than 1.5, you can see same flow chart, pregnancy more than 34 weeks delivery, pregnancy less than 34 weeks IUT. Is this understood to all of you? So you can see over here, okay, zone 3 management and more than 1.5 MOM management is absolutely the same. Can you see this? Okay. Zone 3 management and middle cerebral artery management of more than 1.5 and the pregnancy is less than 34 weeks is cut, copy, paste, same. Okay. Okay, zone 3 में भी हम IUT देंगे, more than 1.5 also IUT you will get. Okay. And if it is more than 34 weeks, delivery, more than 34 weeks delivery. Okay, clap if you feel happy. Nobody will teach you all this point is my guarantee, and all these questions may or may not come in the future exams. Okay, and that is why this question which you got over here, which I had written over here, okay, what is the answer? Okay, this MCQ which I told you. Yes, this MCQ, 34 weeks RH negative, 28 weeks ICT positive, amniocentesis delta 450 zone 3, or they will say on color Doppler peak systolic velocity in the middle cerebral artery more than 1 point. They will say it is, they will say example, they will say 2. It is more than 2 MOM. Answer is the same, IUT, because we are only 28 weeks. Okay. So either you do amnio, but usme poking needle, everything, every time you have to poke needle, or instead of that directly do color Doppler, just do sonography, color Doppler करके पता चल जाएगा basically IUT is required or not. Okay, 28 weeks के बदले अगर answer is, question is 34-35 weeks, then you induce the labor or do C-section and get the baby out. Okay, is it clear to all of you? Yes. The last part, okay, sir, after the baby is born, so basically ICT should remain negative lifelong. Is this understood to all of you? This is the most important table, all of you. Okay, sir, anti-D is to prevent antibody formation if the antibody is already present. How will I come to know antibody is present? If the mother's ICT is positive. So mother's ICT should remain negative. So you will give anti-D to prevent antibody formation. So when I give before giving anti-D, ICT should be negative or ICT should be positive? I will only give anti-D to the patient whose ICT is negative. Is this understood to all of you? If the ICT is negative, then only there is a point of giving anti-D injection. Okay. Yes, very good. I see. Basically, if anybody, all your patients in the world, RH negative lady, अगर world में कोई भी RH negative है, उसका ICT should be negative. Simple. ICT negative मतलब she is normal. She has not yet got the antibody. Okay. If the antibody is present, that is indicated by doing ICT test, ICT positive. And if ICT is positive, then anti-D is useless. Anti-D has got no role. Okay, so now all of you pay attention. What was the toughest MCQ asked? Yeah, now how much anti-D we gave? So normally remember that 300 microgram anti-D, which I will give, will protect the mother from 15 ml of RH positive cells. Okay, yes, we have to do, of course, Bilal, early cord clamping. Yes, I told you, in this case, do early cord clamping. Okay, or 30 ml of the fetal whole blood. Okay. Please by heart this number. The anti-D which we give 300 microgram will protect the mother from how much feto-maternal hemorrhage? 30 ml of whole blood. पूरा blood है तो 30 ml तक leaking होगा is good, or 15 ml of RBCs. Okay, 50 ml of RBCs. हाँ बेटा Jan 24 का बता रहे 300 microgram आंसर नहीं था बेटा. Okay, we'll discuss that. Okay, what are the answer? Okay, so now please pay attention. Okay, I discussed this in my lectures. Okay, and my students got it correct. So now please understand this. So 300 microgram anti-D we will give. That is after the baby delivery. Now all of you pay attention. Okay, sir, after the baby is born, we are coming to that. Okay, after the this is two approach I told you. After the baby is born. Okay, so all of you pay attention. I have got a RH negative mother. married to a RH positive husband, obviously husband or the father, husband is RH positive. Now after the baby birth, what do I do? After, and her ICT is negative. Very good. ICT negative is understood. And after baby delivery, what do? We do the baby ka blood group. Correct or not? After the baby is born, we do the baby blood group. Correct? Suppose the baby is RH negative. What is to be done? Baby blood group is a RH negative. Because baby could be negative or positive, na? So baby blood group is done. And baby has got mother's blood group. Yes, nothing to be done. Baby blood group is RH negative. Nothing. No, Bilal, wrong. Clean bold. Nothing to be done. Because baby was negative. ये negative baby ने अगर leak किया भी है तो कोई problem नहीं है. Nothing to be done. Okay. But if the baby blood group is RH positive, then what you said, Bilal, is perfectly correct, that within 72 hours, as early as possible, full dose 300 microgram anti-D injection I will give to the mother. Is this understood to all of you? So after baby delivery, I will do the baby blood group and I will give anti-D to the mother depending if the baby is RH positive. Okay, as soon as possible. Yes. Okay. Now my point for all of you. Okay, sir, ये तो baby born हो गया. That's why I can do baby blood group. But sir, all of you tell me, when I am doing a MTP and I am sucking this baby out, is it possible for me to find out this baby's blood group? Or suppose this is the ectopic pregnancy which is stuck in the tube and I am treating it or it ruptures. Is it possible for me to find out ye baby ka blood group? No, never. Okay, never. How will I know this baby ka blood group which I suck out in MTP or ectopic? So it is assumed. Prevention is better than cure. Prevention is better than cure. And therefore you assume, okay, sir, when the mother is RH negative, and the husband is RH positive, her husband is RH positive, and provided her ICT is negative, after doing MTP and ectopic pregnancy management also, you will give anti-D injection to the mother. Is this understood to all of you? And here, sir, if we are in the first trimester, then only 50 microgram anti-D is required. Is this clear? Yes, ICT in the mother has to be done. Mother ICT has to be negative. Okay. So is this understood? तो हम ये assume करते हैं because see baby का delivery के बाद baby blood group I can find out, but the baby which is stuck inside the tube or the baby which I suck out in MTP, I assume, you assume that this baby, you have to assume that the baby is RH positive. Is this clear to all of you? Beta, this table, Navrat, ये table देख लो, okay? This is the table which you need to do. Okay, sir, whenever there is a first trimester MTP, 50 microgram, and this was the MCQ in the exam. Is it clear? What was the MCQ in the Jan 2024 FMG exam? Okay, the mother is RH negative and she is undergoing MTP at 11 weeks of pregnancy. Well, I no need to give anti-D, give anti-D 300 microgram, 50 microgram. 50 microgram. Is this understood, Navrat? Okay. Similar with any first trimester ectopic pregnancy. So again, 50. Okay. Similarly, if anything to do in the second trimester, then you give 300 after delivery. After delivery of what? After delivery of a RH positive baby. After delivery of a RH positive baby. Okay. Is this understood to all of you? What is the dose? 300 microgram. So anything to do with the anything to do in the first trimester, the dose is 50 microgram. Anything to do in the second trimester and delivery, the dose is 300 microgram. Is this understood to all of you? In this, all of you, it is understood. Okay, this is anti-D given to a RH negative mother. Provided the partner, what are the three conditions? Sir, mother should be negative. The father or the husband should be RH. RH what? Father should be RH. Father should be RH positive. And the mother का ICT should be negative. ये सब MCQ में actually they should give, but they don't give. They give all half, आधा अधूरा MCQ. They should say, okay, sir, when the mother is RH negative, married to R, they just give this, mother RH negative. Will you give anti-D? No, sir. If the father is also negative, I don't give anti-D. Okay. Yes. Excellent, all of you. Is this understood to you, Navrat? This is basically what I'm telling you is, okay, sir, when I do the MTP or when there is ectopic pregnancy, it is not possible for me to find out the baby blood group. Is it clear? After delivery of a RH positive baby, I will give anti-D. All of you know that after delivery of a RH negative baby, if the baby is RH negative, then there is no need of anti-D. No need of anti-D. Okay. Yes, all procedure. Very good. Any procedure. Correct. Anything to do in the first trimester. If you have done a chorionic villus sampling also, yes, in the first trimester. Any surgery done. Okay. Any surgery done, any ectopic, anything. Basically कहने का मतलब क्या है? Is it clear, Navrat? आपको भी समझ में आ गया कि sir, if the baby is RH negative, there is no need of anti-D. No need of anti-D injection. So, sir, when it is a MTP, I will not find out. It is not possible for me to find out the baby blood group. तो क्या दो ऑप्शन है? Sir, either you say कि baby is RH negative and I will not give anti-D. But उससे अच्छा prevention is better than cure. So you assume. What is the assumption? You assume that it is a RH positive baby. Okay. Beta, how much it is after delivery? It is how much? After delivery of RH positive acid negative, why? Then why 50 gram beta? 300 microgram. Okay. Only thing in the first. Okay. So you assume that it's a RH positive baby. Okay. All this is on the assumption that there is a RH positive baby. Yes. And then accordingly you decide for the trimester. Anything to do in the first trimester is 50. Anything to do in the last trimester is 300. Okay. Is this understood to all of you? ये सब कोई नहीं पूछेगा. ये खाली क्वेश्चन बाहर करने के लिए बाहर कर लो. 50 माइक्रोग्राम है. Second trimester amniocentesis for whatever done, beta. Any procedure. Second, which I do for Down syndrome. Down syndrome amniocentesis. Second trimester amniocentesis for Down syndrome. For trisomy 21, suppose if you have done. Okay, then again you will give. Anything to do in the second trimester. External cephalic version kiya. Any place where your feto-maternal hemorrhage is expected. Suppose I'm doing a second trimester MTP. When you do na, कि नहीं, baby को quadruple marker test is positive. What will you do? Amniocentesis. Okay. So this is your 300 microgram anti. Okay. So nothing more will be expected in the exam is my guarantee. It is 11:30. A small break for 10 minutes. And when we come back, a 45-minute session to show you all the some new images, some old images. It's going to be a very fabulous session. And then of course, list of important topics I've already given to you. And then I will meet you again in the month of April or May for the full test and discussion, where again all these MCQs will also be discussed. Okay, so is this understood to all of you? You just have to remember only one line, that ICT should be negative. If the ICT is positive, there is no point giving anti-D injection, no role of anti-D. Okay, and if the baby is born, baby blood group I can do, and then give anti-D 300 micro. Anything in the first trimester, you assume baby is Rh positive and you give 50 micro. Okay, so it is a break for 10 to 15 minutes. We come back, we continue further. Okay. Hello, hello, hello. Welcome all of you. Is the audio video all clear? Can all of you hear me? Can all of you see me? Very good. Okay. So all of you, these are some of the these are some of the images which we are going to discuss now. These are the some are repetition and some are new, because I had remembered I told you I'll be showing you the green filter and like that, this one. Okay, the MCQs. Okay, so quickly all of you do come back, and yes. So now can anybody identify? Yes, Harry, yes, this is the last class for OBGY. In this session, by in this session, I mean the class which we had for the OBGY theory and this one section. There will be one more test and discussion batch where I'll be coming. Depends, 1 day or 2 day, where we will be discussing. Mostly it's going to be 1 day class where we will be discussing all the gynecology MCQs and all the obstetric MCQ. Will be like, it will be in this kind of a format, like where I will be showing you the question on the board and then you will be answering the question. So like that, almost all the PYQs and all the virgin MCQs will be done in this, and you need to see the previous yeah. So in the TND revision will happen, no? Hmm. Yeah, if that is that, I will discuss with Ashish sir how many days they want and what they want. Okay. Yeah. Okay. So yes. Now what is this? Sir, this is a hysterosalpingography. Now why is it very good? All of you clap. So I'm so happy that all of you are. This is of course a virgin MCQ. Nobody has taught you all this. But this is not a normal HSGY, because in normal HSG triangle, this part is what? This is the uterus. This is one. This tube is not being seen. Okay, so this is what side? This is right side. So it is a right sided cornual block, but the left tube is normal. Why I am saying? Because so beautifully you can see this left tube, and you can also see the, what is this called as the spill of the dye. Is this understood to all of you? So this is a image where we, it is not a left sided cornal block, it's not a bilateral cornal block. This is the uterus and this is the HSG. Of course, a virgin MCQ. This is just to show you a revision. Next, now anybody, what is this? Somebody was asking different shapes of the uterus. So now can you see what has happened over here? Normal uterus is triangle. Normal uterus is always triangle in shape. Okay, here what is happening is only one side of the uterus is seen, and this is a banana shaped uterus. So this is a unicornuate uterus. Is this understood to all of you? So of course a difficult MCQ may come in the future exams. Very good. This is only on one side we are seeing, and of course the tube is also seen, spill is also seen. Okay, is this understood to all of you? So this is a unicornuate uterus. Of course difficult. This MCQ has been asked in the NEET PG, may come in the FMG exam also. Okay, so this is also called as banana shape or half shape. Now I am going to show you two images. In both you can see something like a double cavity. Okay, double cavity. So anybody, which is what? And how do I know whether which is a septate uterus and which is a bicornuate uterus? So which is a septate uterus and which is a bicornuate uterus? Yes. So now in this, what we are going to do, of course, it is very, very difficult. And the confirmatory is always by, very good, all of X. Confirmation is always by hysterolaparoscopy. So this was the MCQ 1 year back in the NEET PG or FMG, that when any Mullerian anomaly is there, we need to confirm by doing a hysterolaparoscopy. Yes. So now please understand this. What you need to keep in mind is that when the two horns, okay, when the two horns are, okay, I just 1 second, I'll just add a few and show, keep, just a second, all of you. So now please understand this, that in a septate uterus, septum is where, sir, septum is projecting inside the uterine cavity, isn't it? Septum is projecting inside the uterine cavity, and therefore suppose when I push the die will only enter this part, isn't it? Common sense. So here what will happen is, what is the trick? What is the trick? Yes, we'll send you this slide also, of course. Okay. Yes. What is the trick or what is the dictum? Okay, sir, here when I will look at the picture, so dye will enter all over here, and common sense, the dye will not enter in this part. This is the septum. So here the dye will not enter. So the two cavity which I will see will something be like this, isn't it? So here you measure the angle. Now of course all this is very difficult in the exam, always sir kaise measure karenge angle, all that, but you are supposed to measure the angle between the two cavities what you see, and if it is a acute angle, it is a septate uterus or a septum. Okay. But in bicornuate क्या होता है? The two horns are going to be widely apart. दोनों horns are going to be widely apart, and therefore when I will measure the angle will be obtuse angle, this angle, okay, and then it is a bicornuate. Okay, so all this is absolutely PG level, and this you can make out. Okay, so this angle which I am seeing is a acute angle, and therefore I am calling this as septate. This you can clearly see, okay, this is going to be more than 120, 140 degree. It's a wide mouth angle. So this is a obtuse angle. So this is a bicornuate uterus. Is this understood? Clap if you have learned something new. So you need to measure the angle between this and find out this. Okay. So if it is an acute angle, we call it as septate. If it is a obtuse angle, we call it as bicornuate uterus. On HSG, the MCQ will be asked to you, how do I confirm all these anomalies? Hysterolaparoscopy is the gold standard to confirm it. Okay, is this clear to all of you? Yes, anything more than this one? Is it clear? So this is your septate and okay. Next, moving on to the, so keep this in mind. Okay. Yes. Now anybody, what is this surgery? What is this thing picture? So this is the uterus. This is the ovary. And this is, we held the fallopian tube. And what is all this blue color dye coming? Which is this blue color dye? MCQ. Yes, of course, Harry. Yes, nowadays FMG, PG almost same. Not almost same, but equal. Yes, absolutely correct. That's why I have taught you the difficult part only. बेटा ऋषि रॉन्ग, रूबिन स्ट्रेसेस कचरा डस्टबिन, ये कौन सा व्यू है? Yes, very good, Rishi. This is the methylene blue dye. Excellent. This is the methylene blue dye, and this is a laparoscopy chromoperturbation. Laparoscopy, not hysteroscopy. I've shown you the picture. Go back and check the lecture. Okay. Hysteroscopy, you are seeing the inside of the uterus with the cavity. Moment you see the hysteroscopy, mein beta, you cannot see the tube and the ovary. Okay, hysteroscopy mein will you see the uterus from outside? No, this is the pelvis. Can you see this is the omentum? This is the pouch of Douglas. You are seeing this yellow omentum. You are seeing the whole tube. This is the methylene blue dye. This is laparoscopy and chromoperturbation. Very important. It's not laparoscopy, tubal ligation. And in hysteroscopy, we never put a methylene blue dye. Hysteroscopy, what are we seeing? Hysteroscopy, as I told you, we are going to see only like a cave. Hysteroscopy will just give you like this circle, and you are only going to see the inside of the uterus with the, we are going to see the inside. Yes, we are only going to see the cavity of the uterus in the hysteroscopy, and we only see the cornual end of the tube. Okay, it's going to be like a cavity ke jaisa picture, as if kya hai aapko. Okay, you just see the inside of the uterus. You look at the cavity of the uterus in hysteroscopy. Yes, inside view. Okay, yes. So this is the laparoscopy view. Next, what is this? Yes, this also I told you, I'll show you. इसको क्या बोलते हैं? This is the, what is the description? Multiple hemorrhages on the cervix. This is what cervix? What fruit? Yes. So this is the strawberry cervix, which is not all of the above, which is seen in trichomoniasis. Okay, this is understood to all of you. So this is the strawberry cervix which you see in trichomoniasis. Okay, is this understood to all of you? Now, what is this? This is a dermatology MCQ. Dermatology MCQ. At the nape of the neck, obesity, PCOS. Patient has got, what is this? Cutaneous marker. Yes, sir. At the nape of the neck, black velvety patches of skin. This is acanthosis nigricans. Okay, this is acanthosis nigricans. This is a marker for insulin resistance. Okay, and very good, all of you, excellent. And we need to tell the patient weight loss and metformin and all the things we need to tell the patient. Okay. Moving on to the next image, which is, yes. Now please pay attention. This is, don't go for the answer. This is the cervix. This we are seeing the cervix. This is the anterior lip of the cervix. This is the posterior lip. This is the cervical opening. This what you are seeing is the speculum. Okay. Now can you tell me the whole picture is looking what color? ये जो पूरा picture है is looking what color? What is the color which we are seeing on the board, on the slide? Okay, this whole picture is looking green in color. Very good. This whole picture is definitely looking green in color. And therefore, what is this? Anybody? This is a colposcopy green filter. Of course, it is a virgin image. This question has never been asked to you. The question which has only come to you in the exam is what? That what filter? Yes. So this is a colposcopy image. Question has only been asked. If you go back and check my cancer class, okay, sir, in colposcopy, which filter is used? Blue, red, yellow, green. What is the answer? Green filter is used. Okay, green filter is used. Okay, green filter is used for the colposcopy. Okay, so green filter is used to see what? The blood vessels. Okay, with the green filter we see the vessels better. Okay, so I promised you I will show you this picture. That's why only thing. Okay, to visual. Yes, very good. Okay. Yes, normally is yellow light. Very good, all of you. So excellent. Okay, so normally is yellow light, and this is the cervix. This is the cervix ka lip. This is cervix ka anterior lip. This is posterior lip, and this is the filter, green color picture. Okay, just remember green filter. Now, anybody revision? What is this device? Completely white. White is white. Okay, white is white, and this is not copper. Not copper. All are this is not copper. Can you see copper wire? Can you see copper wire? No. What is? Can you see a copper wire? Copper team make very good, Priya. Very Bilal wrong. Rohan wrong. Okay, this is wrong. This is a LNG intrauterine device, also called as Myrina. Multi-load, I had shown all of you, multi-load, you get this sun ray appearance. I had told you this. In multi-load, there is a sun ray. You need to go back and see the okay, revision. Okay. And in multi-load, you have a the vertical stem, and in the vertical stem there is a copper wire. Yes, Myrina, correct. Myrina is same as my LNG IUD. Yes, so Myrina is a brand name, so you should always know the should not know the brand name. This is Myrina. Absolutely. This is a hormone cylinder. See, there's no copper. Okay, total how much LNG IUD, how much LNG does it contain totally? 52 milligrams of LNG. And how much it is released per day? 20 microgram per day. Okay, both these questions have been asked to you in the exam. Yes, this is Myrina, LNG IUD, all of you correct. Yes. Shobna, Imad, Harshit, Sadia, Wazim. Yes, excellent, all of you. Yes. Okay, 52 milligram is the total. Copper है ही नहीं. Copper है ही नहीं. This is not copper. In copper tea, you will get a copper wire. Multi-load, you will see a copper wire. Okay. Yes. Now this is what all of you pay attention. This we have again a laparoscopy view. This is the uterus, and this is the fallopian tube, and I have put this white color rubber band. So what is this rubber band for? And I have made a loop of the tube. So this is a, yes, Sila, very good, all of you. So this is a laparoscopic sterilization surgery. Laparoscopic sterilization surgery. Okay. Excellent, all of you. Excellent. Laparoscopic tubal sterilization. This is the uterus, and this is the loop of the tube which gets created, and this, what you are seeing perfectly correct, is the silastic band. Okay, silastic band which you apply. So yes, lap sterilization or lap tubal ligation, whatever you call. Okay, yes, perfectly correct. Now this is again, as I told, I had promised you, I will show you this picture again. It has never been asked to you. This is the liver. Anybody can make out that this is a liver. This is the under surface of the diaphragm, and these are all the adhesions. So this is a perihepatic adhesion called as the Fitzhugh-Curtis syndrome. Okay, Fitzhugh-Curtis syndrome, or the perihepatic adhesions. Okay, is this understood to all of you? Yes. Okay. Yes, very good. As a sequel of PID. Very good, all of you. Okay. Now, going on. Now, please pay attention. This is something new. If you know it is good, even if you don't know it is okay. This is the uterus. They will obviously tell you that this is a transvaginal. Whenever you see a curve like this, it's a transvaginal sonography. And this is, they will tell you this is transvaginal of the uterus. Its focus is more on the endometrium. And this is the whole endometrium. And here can all of you see a structure like this. Okay, so now this structure, two things. Yes, this structure, is it looking like the same ecogenicity as the endometrium? Yes. See, the endometrium ka bhi color ecogenicity, matlab whether it is black, hypoechoic or hyperechoic, or so this is the same structure. This is like the same color of the endometrium, and what arises from the endometrium is a polyp. Okay, beta Arun Chand, endometriosis lecture you will have to revise. Endometriosis के लिए laparoscopy is the investigation of choice. You will have to, this is the ultrasonography of the uterus. Endometriosis में everything is outside the uterus, isn't it? In endometriosis, we will see the uterus, and we will see the tube, we will see the adhesions, and what we will see, all of you, we get what? All colorful picture, isn't it? Red berry, blueberry, blue raspberry, all these are endometriotic implants. You will get this red color lesions, you will get this gunshot appearance, you will see a chocolate cyst. Yes, fruit salad, very good. Okay, you will see a chocolate cyst, and you will see red, blue, black, alag different colors. Okay, blue raspberry, purple raspberry, red berry, blueberry, all that lesions. Okay, and you get a chocolate cyst, and of course black color. Black color spots को क्या बोलते हैं? Matchstick burn spots or yes, very good. So everything is outside it. So here point number one, it is as the same. Of course, a very difficult image, don't worry. And in this, what you see over here, so this is the polyp. And can you see this orange color? So this is a color Doppler. We have also done a color Doppler. And in the color Doppler, when this is the polyp, this is a polyp, and inside the polyp there will always be a blood vessel. जो polyp होगा, polyp will always have a blood vessel. So this is seen that this is that blood vessel on color Doppler. This is called as the feeding vessel sign. Okay, is this understood to all of you? Feeding vessel sign, very difficult, don't worry, this will not be asked to you, but this is a endometrial polyp. Okay, endometrial polyp, which you see. Fibroid is hypoechoic. Fibroid will be like a well circumscribed inside the muscle area, hypoechoic. Endometriosis is all outside the uterus. So there's a polyp, and this is the feeding vessel sign. ओके, ऑन कलर डॉपलर, बिकॉज एवरी पॉलिप के अंदर एक वेसल होता है, ब्लड वेसल होता है. येस, नाउ प्लीज डोंट डिसअपॉइंट मी. वी हैव डिस्कस दिस. 15-year-old गर्ल हैज कम टू अस विथ प्राइमरी amenorrhea, cyclical abdominal pain, urinary retention, very obvious. This picture has been asked. And can you see what is it? Bluish, purplish, tense, bulging hymen. Yes, all of you, this is a imperforate hymen. And what is the treatment for this? Yes, hematocolpus, hematometra, and cruciate incision. Cruciate incision you will take on the hymen. Okay, cruciate incision you will put over here like this. Okay, you just cut it out. Okay, yes, so this is the imperforate hymen. Okay, now this again we have discussed this, that when a patient has been treated with ovulation induction medicines, specifically HMG, recombinant FSH, and then HCG is given for the rupture. Multiple big follicles are there. This is OHSS. Very good. Last year's image. Okay, so all multiple big follicle, all multiple big follicle, all multiple big follicles which we get, and all are in the center. Do not confuse this with PCOS. Why? This is not PCOS, all of you, because sir, in PCOS there will be multiple small follicles in the periphery. Okay, and in OHSS will be all big follicle and all coming in the center also. Okay, yes, necklace of pearl pattern. Okay, so now going on to some of the images in obstetrics. Anybody, what is this maneuver for the after coming head? Burns Marshall maneuver. Okay, Burns Marshall, you hold the baby by the lower limb and you will rotate it up towards the mother abdomen. जैसे जैसे baby will keep on coming here, this head will pop out from here. So Burns Marshall, this is a previous year MCQ. Okay, nothing much, we already discussed. This is also shown to you. We are delivering the after coming head. After coming head का delivery है, because the breech is outside. Can all of you see the forceps blade? What is the special forceps? Piper's forceps. Okay, Piper's forceps to deliver the after coming head of the breech. Yes. Okay, very good, all of you. Excellent. So see what I had taught you 7-10 days ago. This topic was discussed 7 days ago, 10 days ago. You are still remembering it, and lifelong you will remember, is my guarantee. Okay, yes. What is this again? The simple picture. So this is breech. We are converting the breech baby into vertex or into cephalics, and through external maneuver, this is external cephalic version. External cephalic version. It is not an internal podalic. It's not called external rotation. This external rotation is under normal delivery, after delivery. Very good, all of you. So this is ECV. When do we do ECV? Anybody? When do we do ECV? ECV is done around 36 completed weeks. Don't do early. Okay, never do. I've explained to you in detail 30 to 35 around 36 completed weeks. Okay. Now, what is this again? So this is, we are delivering the this is the umbilical cord, and this is the hand, and this is control cord traction. This is control cord traction to deliver the placenta, and this is called as the Brand Andrews method. Very good, all of you. Yes. Okay, Brand Andrews method, control cord traction to deliver the placenta. Again, a very important image. Okay, Brand Andrews maneuver. So all this is like a revision. Some images were new, like your green filter I wanted to show you, strawberry cervix, Fitzhugh-Curtis syndrome, and some of them are the revision which has been asked to you in the exam. Okay, so all these were the some of the images, and of course during the course of the lectures I've shown you all the images, but this I thought will just give you some of the important images. Okay, so all of you, of course I will send across all these images, and I hope you have kept this thing in mind. This is something very new. Please keep in mind about the septate uterus, unicornuate uterus, and the bicornuate uterus. Okay, I repeat that when it is like only on deviated to one side, then you have a banana shaped uterus. That is the unicornuate. And when you have got two cavities, when you see, just see the angle between them, and you will come to know with acute and obtuse angle, we will come to know how the things are. Okay, so we have covered our, of course, the Telegram group will be on. And one more thing also, please don't miss out, in the previous lecture towards the end, I have given you a list of important topics. Okay, so that list of important topics has already been told to you. Yes or no, thumbs up. And also the PDF I have sent to the classes, Mr. Biman already, and I think he has also uploaded the PDF. So in that, the list of important topics is already there. Please focus on that. As I said, during the course of this, let's say 7, 10, 15 days, whatever we were there, like almost 2 weeks which we were there, we have covered everything what is required from the FMG exam point of view, and even from NEET PG point of view. We have not given you the basic information, just the basic information I have not taught. I have taught the highest level of gynecology, like even the toughest laparoscopy, the toughest this one, everything, all difficult MCQ, all virgin MCQ, everything has been covered for all of you. And as a last trick, and I'll tell you when we are meeting and what we are doing also. Okay, so one more important point is that all of you are, majority of you are aware, but those who are new, because many of the students may want to only revise OBGY, there's also a rapid revision MCQ discussion course also available. Okay, suppose you don't want to go for the entire course, because this will be like a repetition. Your batch has already heard my lectures. Okay, but some of you may just want to go for a MCQ discussion. Okay, chalo, let us with sir just discuss lots of MCQs. So there is 15, 16, 17 hours. So many of the students just last 1-2 months, and it's valid for 3 months. Okay, so that all of you. So point number 1, please do follow on the YouTube. If you haven't already yet, please request all of you. This is also the Instagram. So please quickly scan it and click a photo and whatever. And this you can also follow me on the YouTube channel. And this is what, please tell all your friends, this is the app ke liye, and this is a special app for all the students and at a very, very low cost. Okay, there's theory, lecture, MCQ discussion, all of you are aware of it. So please tell all your friends and colleagues, okay, those who haven't heard my lectures, and even if those who want to, some of you have already joined, I know that those who want to again hear my lecture again and again. Okay, because the exam is in June, July, I would want to quickly study OBGY from you, and only in the there's a rapid revision course. Okay, there's a rapid revision course which is just 900 rupees, where you get entire 16 to 17 hours of MCQ discussion. Okay, what we have done, and also new question and all the versions. Of course, I'm going to come again for you for 1 or 2 days more to see this. So you can definitely just go for it. And of course, all of you know that we had a fabulous response in the FMG exam and 100% strike rate. And these are the notes, also sample notes, which are available with the app. Okay, the handwritten note. Okay, and this is of course there. So I request all of you, and mainly tell all your friends and colleagues about this app, so that they can also make use of the OBGY videos. And all of you, because somebody was asking me, sir, this, then there is only a rapid revision only for MCQs. Only MCQ discussion is also available in the form of rapid revision. So all of you may want to go for it, and it's just in 2 to 3 days, in 4 to 5 days, all your MCQs will be done. Okay, so you can just download the app and also make use of this. Apart from this, and as I said, that I will again be meeting you. This is not the last time. Of course, on the YouTube channel also we will meet, and I will be yeah, but that, as whatever Ashish sir will decide, of course I'll be there. Okay, like how last time we had done. So YouTube also live we will do. Of course we will be coming. So you can tell Ashish sir, because he is the boss. Whatever he will tell me, I'm ready to do everything for the student. So definitely you tell Ashish sir that we want Punit sir for the YouTube session few days before the exam, 1 month before the exam, in the month of May I will come. You tell sir we want a 2-day test and discussion, I will come. You want 1 day, but definitely 1 day means I feel 1 day to lagega, because there are 2 subjects, obs and gynae. So on 1 day, so when we come for the test and discussion, at that time only, that time I hope you please see these videos and come. That time only the question paper will be in front of, like this MCQ will come in front of you. Okay, MCQ will come and A, B, C, D options will be there. And all of you will tell me what is the answer, and of course detailed explanatory answers I will give you. So I will conduct one session We'll conduct one session for gynae MCQs, infertility, contraception, prolapse, fibroid, and one session for obstetric MCQ. All this, trust me, student, from that only will come in the exam is my guarantee. Okay, so that discussion, and if sir says that, and if you tell, okay, sir, we want 2 days, then we can also have 1 day rapid revision class and 1 day this test. And so whatever is Ashish sir will tell me, we are here to help all of you out. Don't worry. And of course on YouTube, I would love to come and the test and discussion also will be conducting, yes, as and when. Okay, so best of luck all of you, and all of you will do very well. And thank you for coming in for the last so many days, and best of luck. And please tell all your friends and colleagues about the app, and definitely do join to the YouTube and Telegram so that we can be in touch. Okay, yes, bye bye, best of luck, and we will be meeting you soon in the upcoming months with many more sessions. But thank you very much.